presentation is on a unique tear pattern, that is a radial tear through and through the body of the medial meniscus. This is my profile in brief. All of us are aware that the common meniscus tear patterns are the longitudinal tear, the horizontal cleavage tear, flap tears, bucket handle meniscus tears, and radial tears. We often see radial tears only through the white zone and they are amenable to partial meniscectomies. But what do we do when the radial tears are gone through and through from the white zone all the way to the capsular zone, especially at the level of the body? That's the crux of this talk. This is the common type of radial tear we all know about and we see in our practices. That's a radial tear near the root of the lateral meniscus. And we all have our own tips and tricks to handle this tear using all inside devices or using side to side stitches using knee scorpion like devices, as we are aware that these have to be repaired. This understanding was brought initially by Christopher Hahner, who said that whenever there's a radial tear, there is a very high risk of extrusion and thereby osteoarthritis, and that if there is a radial tear, especially near the root, the knee behaves like a meniscectomized knee if a meniscectomy is done. Like if a partial meniscectomy is done, the knee will behave like a totally meniscectomized knee. This was brought to our attention by Christopher Hahner. Robert Laprade pointed out very clearly that if you do the repair of these radial tears, the results are far superior to a meniscectomy, and it is much cost effective because the patient doesn't land up with significant arthritis requiring knee replacements. With this understanding, I'd like to present this patient who was a 40-year-old male who had a minor twisting injury to his right knee, and he had no prior symptoms in that knee. He presented with severe debilitating pain, limp, inability to bear weight without support. Clinical findings were that he had significant medial joint line tenderness. His alignment clinically was normal. However, we always confirm this with a scanogram, and that his Mikuli line is going through the center of the knee. This was his MRI appearance of the radial tear through and through the body of the meniscus. As you can see, it's going all the way to the capsule. It's almost as if a scissor is taken and cut through the meniscus. These are the coronal oblique images and the sagittal images, which again demonstrate this through and through radial tear at the level of the body of the medial meniscus. When we look at this tear, the common treatment options that come to our mind is all inside repair using commercial devices, or inside out repair using inside out needles, or arthroscopic side to side stitches using scorpion like devices. These are the various options. Are there any other options? So this is the paper that has talked about the inside out repair for radial tears at the level of the lateral meniscus with fibrin plot with good results. But the tear in the medial meniscus behaves totally different from the tear in the lateral meniscus, because on the lateral side, we normally have an excellent healing potential. And if you see the video of this particular patient, you will appreciate that the meniscal tissue quality is poor. However, this is not at all an arthritic knee. As you can see, pristine cartilage. It is the internal meniscal degeneration. And to make matters worse, the tear is extending from the white zone all the way to the capsule. So routine techniques of all inside devices or inside out devices or side to side stitches alone is not going to help this situation where there is a significant tear. So in this special situation, we need to have the special tips and tricks. And this is the article by Robert Laprade of the two tunnel technique, which has been described for these sort of a radial tears at the level of the body. And this has been shown to have a very strong biomechanical construct under cyclical loading. This is the original article. And this is exactly the technique that we employed in this patient. The position of the patient is with the thigh holder and the limb hanging down, because it exposes the entire medial aspect and the posteromedial corner. We always start our complex repairs with a pie crusting, palpate the joint line, start with the 18 gauge needle distal to the joint line, directing it posteriorly with a slight valgus force. And as you can see here, it nicely and gently opens up the entire space, because a lot of bulky instruments are going to come inside the joint for this repair, and we do not want to scuff the cartilage, because that's basically the crux of this procedure. You then come with your diamond rasp. You need to spend some time rasping this tissue, because this is not a very good quality tissue, and we need to stimulate biology for healing of this tissue. You rasp both the surfaces of the meniscus. That's the anterior surface. posterior surface, but beware also rasp the capsule because a lot of macrophages will come in from there for the healing of this repair. You then plan two tunnels, one at the back corresponding to the posterior leaf and one at the front corresponding to the anterior leaf. How do you achieve this? This is the image from the Laprade paper wherein he has created two tunnels. These are the guide wires which are corresponding to the posterior flap and the anterior flap. These are the dedicated jigs which are now available. They are low profile and they are angulated for right and left so that they negotiate the tight space of the corresponding knee. This is the tentative planning. An oblique incision is taken on the medial side, and this is the tentative planning of placement of this jig. I use the PCL depth stopper and a PCL guide wire with a laser marking because you cannot afford to drill this in 90-degree flexion and allow the guide wire to progress into the joint because it will definitely damage the medial femoral condyle. So this acts like an auto stop, and the final drilling is done with gentle taps. On the right hand side, you'll see that's the PCL guide wire with the PCL depth stop. On the right hand side, you see the offset guide, which is available with this set, wherein you can drill at fixed offsets at 6 mm or 7 mm from the first guide wire. So this ensures that you've got specifically located tunnels. So that's the image of the two guide wires. Let's see the arthroscopic image of the same. So the low profile jig comes in. You place it first at the posterior border. Now you need to come at the meniscocapsular junction. You need to be right at the meniscocapsular junction. You cannot afford to be too medial or too off the meniscocapsular junction. So that's the posterior guide wire. The final drilling is done gently and protected with a curette. This is the anterior guide wire, which is at about 7 mm offset from the posterior guide wire. Again, protecting it with the curette. So once the two guide wires are drilled, you have to pass stitches through the corresponding posterior portion and the anterior portion. That's the antegrade suture passing device, which is passing a ultra braid suture through the posterior leaf. And you use a different color coded device for the anterior leaf. Another antegrade device, the knee scorpion, is being used for the anterior leaf. You need to go right, you need to take a nice deep bite, direct the needle away from the articular cartilage so that there is minimal scuffing. Color coding helps you in identifying the corresponding sutures passed in the corresponding leaf. You can take an accessory medial portal and station this suture in that accessory medial portal. We now have to pass the sutures through the corresponding 2.5, 2.4 tunnels. So when your assistant is withdrawing the guide wire, you can do circulatory motion, which widens the tunnel, and then immediately identify that spot and use a straight lasso-like device which enters the joint and push a HD wire loop into the joint. So that's the lasso, and the wire loop has been retrieved and loaded onto the sutures. And when you pull on the wire loop now, the sutures are pulled into the corresponding tunnel. What's important to understand that the anterior suture is pulled into the posterior tunnel and the posterior suture is pulled into the anterior tunnel, creating this sort of a crisscross pattern. And when it is tightened on a endo button, like you see here, so you can take a normal endo CL, which will give you the suture, ultra braid, and the button, and one suture extra will allow you to create a nice, strong repair. Tightening of the sutures is then done, and you have a nice, stable transosseous repair. But this is not enough. We need to now do inside out sutures with a low profile cannula. You need to do multiple stitches on the upper half and multiple stitches on the lower half. So that's one of the examples. A few tips and tricks. You use a hook probe for your inside out stitches. Push it into the area where you expect your needles to come out. Create a safety incision as described by Laprade. You incise the sartorius fascia first. You do blunt dissection and go in the interval behind the superficial MCL and in this triangle, which is formed by the posteromedial capsule in front, medial head of gastroc behind, and the semimembranosus inferiorly. Once you have this triangle, place a spoon there, and your hook probe is guiding you where your needles are going to come out. With this understanding, use low profile cannulae, which can be turned 180 degrees so that you can negotiate these tight corners on the upper surface of the meniscus and the under surface of the meniscus. This is a video of the same. So we are passing the suture through the undersurface of the meniscus, first to the meniscal tissue. Once passed to the meniscus, drop the knee to about 60-70 degree flexion, and your assistant picks up that needle from the back, being deflected with the spoon. Then through the capsular side, and when you pull on the sutures, it creates the normal meniscal flaunch. So that's the final appearance of two sutures side to side, inside out, passed from above the meniscus and under the meniscus. You need to have additional biology for healing of this meniscus. So you do a notchplasty and these microfracture holes at the level of the intercondylar notch in front of the ACL. The fat globules indicate that you have gone deep enough, and that's the final construct. So the important things to understand is that you need to release the meniscocapsular adhesions. You need to enter into the joint at the meniscocapsular region in order to have an anatomic reduction. Inside out meniscus sutures are very critical for the biomechanics, and a probe is used for creating this incision and for understanding the trajectory. It's important to understand that the transosseous technique helps us in getting further biological factors right at the level of the repair for the healing of the tear. And it's interesting to see the follow-up of this patient. On the left-hand side top, you see the pre-op, and the lower images are of the post-op, about 9 months post-op, where you can see the healed radial meniscus, and you can see the sagittal and the coronal image showing the tunnel and the healed meniscus tissue. What's interesting is his MRI report, that the meniscus repair is still intact. There is no evidence of re-tear. There is no extrusion indicating that we've been able to restore a strong, biomechanically strong construct, and the medial compartment articular cartilage is well preserved. So in a 46-year-old gentleman, we have preserved his cartilage. He's absolutely pain-free and able to carry on with his activities of daily living. So my take-home message is, whenever you encounter these unique tears, that is the radial tears at the mid-body of the medial meniscus, you need to understand these are uncommon and unique tear patterns. If you leave them alone or do a meniscectomy, this will lead to rapid degeneration. If you do a biomechanically weak repair, like all inside repairs or only inside out repairs, also it would not lead to adequate healing and will not be able to prevent chondral degeneration. The LaPrade 2 tunnel technique with 3 to 4 inside out repair sutures, 2 above and 2 below, is, according to me, presently the best way to handle this debilitating injury. Thank you.